Hey everyone, welcome to Rapid Diagnosis with Rapid Rads. I'm Dr. Riley, he's Dr. Cook, and this is a case of a 45-year-old female coming in with severe lower abdominal tenderness. She has a history of constipation in the past, and she's running a little bit of a fever, a little bit tachycardic, and you get your CT abdomen and pelvis, and these are your findings.
So as we scroll through these coronal cuts of this CT scan, our eyes are immediately going to our point of interest in that left lower quadrant. We're looking at that sigmoid colon, and it looks mean. It looks inflamed. The bowel wall is thickened. We see some fat stranding, and we also see some specks of air, those black tiny areas. That's consistent with micro perforations into this valve, which is consistent with a complex sigmoid diverticulitis. And we do want to drag your attention to the other side of the abdomen. Look at that ascending colon. The bowel wall is nice and thin. There is no fat stranding. There's no bowel wall thickening, obviously no perforations. So we can use that as a reference point to just really appreciate how mean that diverticulitis actually is.
Absolutely. And most acute diverticulitis patients, you're sending these home, especially if they don't have risk factors, they don't have lab abnormalities, that kind of stuff. What makes this interesting is that it's a complex case, and why it's complex is because of these microperforations. So we need our general surgery colleagues on board because of this complex case of acute diverticulitis. And on top of that, we need to be giving broad spectrum IV antibiotics, typically covering anaerobes as well as gram positives and gram negatives. And obviously, with all of these things going on, this patient's getting admitted to the hospital as opposed to trialing outpatient oral antibiotics.